Frequency Podcast Network. Stories that matter, podcasts that resonate.
The most recent data indicates that 6.5 million Canadians don't have a family doctor. I would guess that many of you know that firsthand. Even among those who are lucky enough to have one, appointments for all but the most urgent matters can often be tough to come by. Now, there are alternatives. We've reported before on nurse practitioner clinics, where those of us who have the money to spare can get access to nurses who can diagnose and prescribe medication. For those of us without that money, there are walk-in clinics, which are few and far between and crowded. And there's the emergency room, which is always crowded, and these days may sometimes be closed. There is one other option, though, that some provinces have been using to attempt to ease the burden on the healthcare system: giving pharmacists the ability to prescribe some medications for minor ailments. It's currently happening in Ontario, BC, Saskatchewan, Nova Scotia, and Newfoundland. And it's an interesting idea. But of course, it's raised a lot of questions on everything from training to privacy to conflicts of interest to, well, what happens if that minor ailment is major? So how does it work? And is the cost worth the benefit for a system coming apart at the seams? I'm Jordan Heath Rawlings. This is The Big Story. Natalie Mehra is the Executive Director of the Ontario Health Coalition, Ontario, of course, being one of a few provinces that now allows pharmacists to prescribe medications for some minor ailments. Hello, Natalie.
Hello.
Thanks for finding time for us.
Oh, thank you for having me.
Now, I know that this can vary from province to province, but just give us a sense here when we're talking about pharmacists prescribing. What kind of issues are they prescribing for?
Yeah, so, it's common ailments. I wouldn't necessarily say minor, because some can be quite serious, and some, if misdiagnosed, can be very serious indeed. And the consequences of getting it wrong, even if not misdiagnosed necessarily, also can be quite serious. But for example, we would be talking about prescriptions for acid reflux or acne, hemorrhoids, menstrual cramps, nausea and vomiting in pregnancy, oral thrush, yeast infections, urinary tract infections, sprains and strains, pink eye, parasitic worms, things like that. And this is an expanding list. So in Ontario, for example, they expanded the role of pharmacists in 2023 and then expanded it again to 14 more common ailments in 2024. But again, I just want to clarify, I don't think they're necessarily minor ailments. They're common ailments.
I was going to say, when you read that list, I was like, some of those sound pretty bad.
Well, yeah, we have, I'm not a physician, and so I want to qualify what I'm saying by this, but in speaking with the physicians on my board, for example, and others, there are issues around if you, for example, talk about very bad period cramps. They can be a range of different things of varying seriousness and severity. I can speak to this because of personal experience, with a tumor that, presented as, terrible period cramps. So, those things are definitely, can be quite severe. Urinary tract infections can kill people, especially the elderly. And we hear this all the time when they're missed in long-term care homes and people die from them. They're quite a serious thing. Some of the other common ailments that they have listed in the expansion of scope for pharmacists are things that are, minor, not necessarily easy to diagnose, and some are definitely more serious.
So from the perspective of the province, I guess, of Ontario, but also probably it's the same problem elsewhere that have done this. Why make this move? What's the purpose here?
Well, I think what's happening is that the pharmacy chains are lobbying for it because it's money for them. I think that's where it's coming from. The pharmacists, the professionals, their unions have not been lobbying for it. There is no question that obviously if you have pharmacists able to do more of the job of family doctors in local pharmacies, in the context of severe shortages of family docs, you would expand access to primary care. That's what we call family doctors, nurse practitioners, family health teams, or community health centers or the like across the provinces. It's the front door of medicine. The policy justification might be to expand access to primary care. However, the question is it appropriate? Is it safe? Are there other risks or negative effects of doing it?
That makes sense. And we're going to get into the possible problems, but also what other solutions might be out there. So I guess my question, just to set the table for that, is in Ontario, at least, do we know what that looks like? Like, can I walk up to the pharmacy with a minor ailment and say, I need somebody to diagnose this? Do I need to use my own pharmacy? Do I need to book an appointment? Like, how exactly does this work? Or is there not really much governing it?
Yeah, so you can walk into a pharmacy or call and make an appointment and do this. It's not like having a family doctor in the way that people were used to, or a nurse practitioner or a family health team. So that, you can do it for the participating pharmacies. I don't quite know how they're dealing with walk-ins, but you definitely can phone and make an appointment, and they will have a system for dealing with walk-ins.
Let's talk about first the issues that you raised. Why are some people concerned with pharmacists prescribing for these ailments? You already mentioned that some of them can be quite serious, but beyond that, what are the worries here?
Well, I think it sort of goes into a few different categories. For really quality primary care, and again, I'm going to say that's the front door of medicine. That's access to your family doc, your nurse practitioner team, whether it's a community health center, Aboriginal health center, or family health team, or the like. Continuity of care is absolutely vital. Knowing a patient's history is crucial to good care. And so with the idea that you could sort of go to any pharmacy and pharmacists could do this without knowing the patient's full history, without necessarily having the time to take the patient's full history and their family history and so on, that raises pretty critical questions around quality of care. The physicians have raised a bunch of issues around quality and safety as well, about pharmacist training. And, their claim that pharmacists are not adequately trained to do this. And while the provinces that have done this talk about it as pharmacists being able to prescribe medications for common ailments and things like that, what it actually entails is a pharmacist being able to diagnose a patient for that condition. And that's a much more serious thing. People go to medical school for years, do an internship at a residency to be able to actually diagnose patients. Physicians are set up to do it with offices where they can do the appropriate physical screening, lay hands on the patient. That's the term for doctors and nurse practitioners. A pharmacist would not necessarily be able to lay hands on the patient and do the same kind of physical checks. And so the question, I think, in all of our minds is one around quality, misdiagnosis, not having the patient's history and continuity of care to ensure that it is safe, appropriate, and that the diagnoses are accurate. And that's the big one. But there are other issues as well.
Yeah, I wanted to ask you, because you mentioned it earlier, that this is something pharmacies have been lobbying for. Why are they lobbying for it, and what role does that play?
Well, across Canada, we've seen a sort of consolidation of chain-owned pharmacies. So in many of our communities, there used to be little independent pharmacies and so on. And now we've seen this explosive growth of companies like Shoppers Drug Mart or Rexall. And these are chain-owned pharmacies. And Shoppers in particular is moving into healthcare in a huge way. You know, they've invested in a virtual care company, Maple, here in Ontario, and other forms of private healthcare. And this would be in keeping with that expansion into more and more of the realm of healthcare. And obviously, they'll do it if they can make money from it. This is a for-profit company. These are for-profit chains that we're talking about. And so that's the attraction.
I was going to say, and this is not to cast aspersions on any particular pharmacist or pharmacy, but there is something to wonder about when, you know, you would be prescribed something by a company that would then sell it to you, like right there on the spot, right? Because presumably they're going to fill that prescription.
Exactly. So that is not allowed for family docs. You can't diagnose a patient, give a prescription, and then sell them that drug or treatment for the illness for which you've just diagnosed them. That's not allowed. In this case, they would absolutely be doing that. It's a conflict of interest. I mean, this has been longstanding. We don't allow that at all for docs, but they're going to allow it for the pharmacies.
I want to ask you about the positives now, because as I mentioned off the intro to this podcast, there are 6.5 million Canadians without a family doctor. For-profit medicine is kind of creeping in with those nurse practitioner clinics. And then beyond that, there's like walk-in clinics and ERs. So like, doesn't this theoretically at least ease some of that burden? Like, isn't something better than nothing for a lot of people who right now have nothing?
For sure. Obviously, if there's no access to primary care in your community, this would provide some access. The issue that I have with that is that, I mean, we absolutely support pharmacists, of course, and they have an incredible level of expertise around drugs and pharmacy, you know. And so ideally, what you'd have is an expanded team-based approach to primary care across Canada. And this has happened to some extent, but nowhere near the extent that it needs to be. And that team would be family docs and nurse practitioners or physician assistants, physiotherapists, occupational therapists, speech language pathologists, social workers, pharmacists, etc., in a team. And the team would decide what was the most appropriate approach for a certain patient. And they would be public and nonprofit, you know, actually democratic, responsive to the community, and community controlled and not controlled by a for-profit multinational corporation. That's the model that we have supported. That does absolutely expand access to primary care because it takes the burden off of physicians and gives them a team to work with and provides better, more kind of holistic care for patients. So this is more like the corporate kind of for-profit alternative to the more kind of progressive, nonprofit, community-controlled, team-based approach that those of us who support sort of the public interest in healthcare have been calling for decades.
What you just described, that team-based approach, sounds utopian. I think everybody who doesn't have access to a doctor right now would love that, but it's not just like a family doctor shortage. We have a nurse shortage. We have a ton of healthcare shortages. So I'm not meaning to be critical of that idea, but like, how is it possible given the current reality of the state of our healthcare system?
Well, you know what? We have shortages of nurses in certain areas of healthcare because they've left, but we do have nurses around. And for example, in Ontario and in other provinces, we have nurse practitioners opening up for-profit clinics because they have no way to bill or charge the public health system. They exist, they're out there, they want to provide care, but they have no mechanism through which to do it. They're not allowed to bill, you know, RAMQ in Quebec or OHIP in Ontario or MSP in British Columbia, for example, the public health system. And so right now we've seen a trend of them opening private clinics. So they do exist. It takes a lot less time to train health professionals than it does docs. And I'm not saying that we shouldn't train more doctors. For sure we should. But one method to deal with the staffing crisis is to expand teams and bring in teams. And we've done it historically. For example, the Community Health Center in Sault Ste. Marie did that. And in Northern Ontario, we've had a bunch of community health centers like that that have provided access to care in areas where traditionally it's hard to get staff. It's a vicious cycle. So if you have a town, for example, I'm going to say Blind River on the north shore of Lake Huron, it's in Northern Ontario, and you have no docs left in that town, but there's 3,600 people in the town alone, right? Not including the surrounding areas. To attract a doctor alone to come and move their family and provide a practice there means that they have to somehow provide care for 3,000, 4,000 people. That's not possible. So they don't go. And so the shortage begets more shortages. To break that cycle, you're going to need a team to do it. And the pharmacies, even though you could expand their scope of practice, regardless of the safety issues and quality issues and so on that I just raised, there's still only a tiny portion of the solution, if you call it a solution, because they can only do a very narrow range of things. So it doesn't actually solve the problem.
In Ontario, if not in other provinces, because they all introduced this at varying times, in Ontario, it's been more than a year since pharmacists started prescribing. You mentioned they expanded the program and the list of things they can prescribe for. Do we know if it's working? What early returns do we have, if any?
Yeah, and for the other provinces, they have also done it. And so, no, we don't have good data on this. And at the very least, if we're going to do this, there may be some data, by the way, available that is not available to the public, like hasn't been publicly disclosed. But the thing is, this is one of the other problems. The patient records from this are then held by the pharmacies, by the pharmacy chains. There are two issues with that. Do they get integrated with the rest of the health system? Do they ever make it back to your family doc?
I was going to ask you about this because this is an issue that we've talked about on this show before, which is that our medical system is way behind just in terms of like sharing digital records and making sure different things are accessible. But I do know that, for instance, if I show up at an ER, right, and I have something I need to go to the emergency room for, that record does get sent to my doctor. But you're saying we don't know if that's happening here or not?
Well, it's not happening unless there is some system in some province that would do that. But otherwise, no, it's not happening. And the other issue with that is, do you want for-profit companies having access to patient records across the board in your province? And, because these companies have an interest in monetizing them. So, for example, it can be, well, we know that there's a cluster of people with this kind of illness in this area, and therefore we can have Facebook ads targeting that geographic area with particular, health medications or health treatments or medical devices and so on, that kind of monetization. So they can't say, supposedly, they're not able to say, you have this disease and we're selling that to a company, but they can monetize that kind of patient information. And that's a problem. And so who controls the records? Are the records integrated at all? And then there's a problem integrating them when you privatize parts of healthcare. And for-profit companies don't have an interest in sharing your patient records and things unless there's a financial interest there. And so you have to sort of think about the consequences of that. And there are others, of course, right, around just making profit off of this. In the long run, is it going to be less expensive? We don't know. On the quality issues, they have an absolute no interest whatsoever in sharing information about accidents, misdiagnoses, etc.
The last thing that I want to ask you, because we've spoken about Ontario, and I know some other provinces have since expanded the list of things that pharmacists can treat. Do you see this program continuing to expand? And I'm not asking you whether or not you think it should, because I think we've covered that. But where do you see this program in 2 or 3 years if you put your most realistic hat on?
Yeah, and I think they are going to continue to expand. And I think we really need to think about better options for primary care that use the team, including pharmacists, vitally. This isn't really about pharmacists. This is really about the corporate owners of the companies, right? And so the drive from them to expand their market share and thus their profit taking is very serious. I've not seen this. I've done this now for, 27 years. And I've not really seen this kind of level of takeover of previously, public nonprofit or individual pharmacists, individual physician-owned healthcare. So you might technically call it for profit, but they are not owned by companies. These are, normal physicians would have been in group practices or their own single practices. I've not seen this before. And I think it's a very, very serious policy shift. I'm glad you're doing this podcast, because once you privatize the ownership of primary care, everything about the practice of medicine changes fundamentally. I think Americans know that, but Canadians I don't think generally understand how much it contorts the practice of medicine.
Natalie, thank you so much for this.
Oh, thank you for doing it.
Natalie Mehra, Executive Director of the Ontario Health Coalition. That was The Big Story. For more from us, you can head to thebigstorypodcast.ca. You can send feedback to hello@thebigstorypodcast.ca or leave a voicemail by calling 416-935-5935. The Big Story is available in your favorite podcast player, and it's on your smart speaker if you ask it to play The Big Story podcast. Thanks for listening. I'm Jordan Heath Rawlings. We'll talk tomorrow.